Right now, over 50 companies are selling ambient AI scribe tools to health systems. Health systems are spending millions to deploy them. Every major EHR vendor has one. The pitch is compelling. The AI listens to your clinical encounter, generates the note, and gives you back hours to your day. And yet, adoption is uneven. Clinicians are disengaging after early bad experiences. And studies are showing modest time savings that don't materialize into actual return on investment. And the clinicians who need this technology the most, the ones drowning in documentation, the ones working in under-resourced community health centers, are often the last ones to get it. This is not a technology failure. The technology works. I've watched it work. But platforms like Abridge, DAX Copilot, and Nuance are technically impressive. The natural language processing is genuinely good. This is a product failure, and the reason is almost always the same. The people building these tools have never spent a shift inside the environment they're building for. Hi, I'm Jennifer Rist. I've launched over $300 million in healthcare platforms, and I've coached many clinicians into product roles in this exact space. And today I'm going to tell you about 4 specific ways ambient AI scribe products fail at the bedside and what a product team with clinical experience would build differently. So if you're building in healthcare AI or trying to break into this space, subscribe. I publish every week on what it actually takes to build and to ship in this healthcare AI environment. So before I get into the 4 failures, I want to be precise about something, because the instinct when a healthcare AI product struggles is to blame the model. The accuracy isn't good enough. The NLP isn't sophisticated enough. The hallucination rate is too high. And sometimes that's true. But research published this year consistently shows something a lot more interesting. The clinicians who benefit most from ambient scribes are not necessarily the ones at the best resourced institutions with the most technically sophisticated tools, right? They're the ones whose individual workflows happen to align with how the product was designed. So adoption follows a bimodal pattern. Heavy users who swear by it and clinicians who tried it once and said it's not for me and I walked away. That gap is almost always a product design problem, not a technology problem. The clinicians who disengage after early bad experiences are not resistant to technology. They ran into a product that wasn't built for the way that they actually work. And the product team never knew because they built it in a conference room on a whiteboard, not with clinicians working by the bedside. So here are 4 places that failure happens most commonly. Failure number 1 is workflow was never part of the design. The product was designed around the note, not around the clinical workflow that produces the note. Here's what that means in practice. A primary care physician doesn't have a clean, linear conversation with a patient that maps nearly to a SOAP note structure. They're managing a patient with maybe 6 chronic conditions, answering a question about a family member's medication, handling a call from the pharmacy, and documenting a procedure, sometimes in the same 15-minute window. Ambient scribes built without deep clinical workflow understanding tend to capture the conversation and they miss the context. They generate a note that looks complete, but it omits the standing order the physician updated 3 visits ago, or it misattributes a medication discussion to the wrong condition, or it structures the assessment in a way that doesn't match how that specialty actually documents. The result here is that clinicians spend as much time correcting the note as they would have spent writing it themselves. And it's not because AI is bad, it's because the product was designed around a workflow that exists on paper, not a real clinical environment. Failure number 2 is the one that kills most ambient AI products more than any other, and it's that the EHR integration was incomplete, and the product team didn't find that out until it was deployed. Health systems run on Epic or Cerner or a combination of both, plus 3 legacy systems that were never supposed to talk to each other. When an ambient scribe generates a note, that note needs to land in the right place, in the right format, and in the right field, automatically, without the clinician having to touch it. That's the goal, right? What actually happens in practice is that the note generates correctly, but the integration puts it in the wrong section of the chart. Or the physician has to copy and paste it into Epic because the API connection isn't fully built, and they find that out later. Or it works perfectly at the academic medical center where the pilot ran, and it breaks completely at the community clinic with a different Epic configuration. A product manager with clinical experience asks a very different set of questions here during this technical scoping. Not just does the API work, but does it work for this specific Epic build at this specific institution for this specific visit type? So you hear all the time, a hospital's a hospital, a hospital, right? So true, because those are 3 different questions, and the answer to the first one tells you almost nothing about the other 2. Failure number 3 is one that the research is now documenting clearly that product teams consistently underestimate is specialty mismatch. So ambient AI scribes were largely developed and validated in primary care settings. Long encounters, conversational documentation, relatively predictable note structures. And in that context, they perform well. Deploy that same product to a cardiologist now that's documenting a complex intervention, or a psychiatrist whose note structure involves highly specific diagnostic language, or even better, an emergency physician who is managing 5 patients simultaneously and documenting in rapid bursts. And you get a completely different product experience. The model was not trained on the documentation patterns of that specialty. The note structure doesn't match what the specialty actually needs, and the errors that get through are not minor. In high-stakes specialties, an ambient AI note that misses a medication nuance or underdocuments a clinical decision is a huge liability, and it's not a time saver. The product teams that get this right, they validate specialty by specialty. They don't launch the whole health system and hope they run into no problems. They run a real pilot in cardiology, a real pilot in psychiatry, a real pilot in the ED department, with clinicians in the room using it, not survey data collected afterward. Failure number 4 is the one that I find most interesting from a product perspective. The notes are technically accurate, but clinicians don't trust them. I hear this all the time. This sounds paradoxical. The model produces a complete, well-structured note like you're on ChatGPT. It sounds amazing. The physician reviews it. It looks right, but they don't feel confident signing it without reviewing each and every line, which takes nearly just as long as writing it in the first place. Why? It's because the note was generated by a system that, much like AI tools I covered in previous video on syncophacy, I still can't say that word, it tends to produce outputs that sound confident and complete, even when they're not. Clinicians who have caught 1 or 2 meaningful errors, especially early on in their adoption, they develop a distrust response that is completely rational. The product failed to build trust. The trust is not a UI or a UX problem. It's a clinical validation problem. And even more importantly, their licenses are on the line for any mistake that could happen. So they are fully responsible. So it's about trust, but it's also they're making sure that what is written is, and what they're signing, because they're signing on this stuff, but they are fully legally responsible for the care that they give and for the notes that they have. So the product teams that solve this don't just improve model accuracy. They build transparency into the product itself. Side-by-side audio and transcript reviews, flagging low confidence sections, making the review workflow fast enough that verification becomes a habit rather than a huge burden. They also define what accurate enough means for each specialty before launch, not after a physician has already had a bad experience. So if you haven't watched my video on the AI synchrophacy, if I could ever say that, in healthcare product teams, link is in the description below. It's directly relevant to what I'm talking about here. I've spent most of this video on what does go wrong. Let me tell you about what goes right when the product team has clinical depth on it. First, they scope the pilot differently. Instead of rolling out to everyone and measuring average adoption, they identify the specific clinician profiles who will benefit the most upfront. It's not that you can't expand. You have to start somewhere. There are physicians who consistently, behind on notes or have longer patient conversations, who document complex chronic conditions, and they prove value there first. Then they expand deliberately. Second, they build the EHR integration as a first-class product requirement, not an afterthought. They map the actual Epic or server configuration at each implementation site before development begins. They treat integration as a feature in its own acceptance criteria, not a technical dependency someone else owns. You are responsible for this part. Third is they run specialty-specific validation before launch, not a pilot with 20 primary care physicians and a hope. Actual structured evaluation in each specialty with documentation quality metrics defined in advance and clinical champions who have accountability for the outcome. And fourth, and most importantly, they design trust into the product from day one. They ask what would make a clinician confident enough to sign this note without reviewing every word. And they build towards that answer, not towards metrics that look good in a vendor presentation, towards trust and for that physician and that clinician to feel confident in what you are providing them. None of this is rocket scientists. We're not rocket scientists at all, right? All of it requires someone in the product room who actually has been in the clinical room. That is the gap. And it is the gap that is costing health systems hundreds of millions of dollars in unperforming AI investments right now. So if you're a clinician who has watched a tool like this get deployed and failed at your hospital, raise your hand. What you observed wasn't a technology problem. It was a product problem. And the instinct you had, I know exactly what they got wrong, is not just valid. It's a skill set that companies building the next generation of these tools are actually looking for. So if you want to know how to close in this area to transition from clinician to a product manager in the healthcare environment and see how close you are to that transition, the clinical PM readiness scorecard is in the description below, and it's free. It's 12 questions that takes 3 minutes. It was built specifically to tell clinicians what they already have, what's missing, and what to do next. And if you're already in product and you're building in the space, I genuinely be interested in your experience with ambient scribe adoption, and drop it in the comments below. The patterns I'm seeing are consistent, but I know that they're not universal. So subscribe for more content on what it actually takes to build healthcare AI products that work in the real world, and share this with someone who needs to see it, the product team at a health AI company or the clinician who just lived through another failed rollout. So we will see you on the next video.